As a pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. Okay, kita biasa belittle our patient last time when we will start working, isn't it? We are the king, we are doctors, so everybody should listen to us. But we forgot that it's an unpleasant sensory or emotional experience that is actually important for us to actually describe the pain. So, associated with actual or potential tissue damage or described in terms of such damage. Okay, so when you are talking about pain, always remember when patients say pain is actually pain. So this is the International Association for Study of Pain descriptions. So how the pain is actually been perceived by our patients. So we got a receptor, okay, where usually is A delta or C fiber horn, when they actually bring the signal to your spinal cord, to the thalamus, state brainstem, to the cortex, where the perceptions of and modulations of perceptions and response to pain being translated, and then go back into your thalamus, brainstem, and the spinal cord, and then give the reactions to whatever necessary to actually avoid that pain. Right? Either you draw back your things from pain, or you manipulate how to actually get the comfort of the pain. That's a normal process. So you got the receptor, you got the so-called cable, and then you got the motherboard processor. Okay, so sounds long journey, isn't it? But the process from here to here and back is in micro or milli or nanosecond, right? I give you an example. You on the Swiss, or the TMB on the Swiss, 100 kilometer away, you almost immediate, you got the power supply, isn't it? So you are talking about the nerve, which is actually electricity conduction, that almost immediate, they will actually respond. So that's why the process is so fast. Okay. So in detail, so you got a nociceptor, free nerve ending, C or A delta, then you got a stimulus, then you actually go through dorsal horn to the spinal cord, and then goes through the spinal thalamic or spinal reticular tracts, and goes into your thalamus brainstem, and then go to cortex, back, they percept, and then go back and give a response. This nociceptor can be found in skin, is actually a lot. And then the somatic structure, joints or viscera, so almost everywhere. And then the response, the nociceptor is actually respond to a certain, not just an inflammation, sometimes the pressure also can actually got that. That's why you got intestinal pain. It's not the inflammation, it's some contractions. Expansion is actually causing the irritations too, and then being translate as pain. So logically, when you have this kind of complex threat, so how you can control? So you should think that, okay, maybe you can actually intercept in whatever level, right? So you can intercept at this level, you can intercept at that level, you can intercept at that level. Okay, so logically, all right, and then a certain treatment that available is actually, it may not be working here, may not be working there, may not be working there. It's not just that you know where to block to control the pain. You have to think that might not be working. All right. So maybe you target, and then after that it's not working. So that's why the turning point is you will need to actually listen to your patients. So when they say pain, it's pain. When they say it's not relief, it's not relief. Right? I remember when I was young, your senior told you confidently, okay, give this pain settle. So you pun follow lah, macam budak bodoh, follow, and patient start complaining. Who do you believe? Your patients, or your senior? Your senior lah. So actually you are the one who bodoh. So remember that the pain is very complex. It can actually affect anywhere. Your treatment can be anywhere, but it might not be working anywhere. So the point is, you need to actually know whether this is actually really pain or not. Of course, there is some small percentage of patient that mengada-ngada lah, right? And remember, you are actually talking about pain threshold as well. Not painful for you, may be very painful to others. Alright? So remember, pain is what the patient says hurt. Okay? And further on top of that, it's not a job about the physical, it's about the emotional as well. Right? So pain is actually, sometimes it's actually not really pain, but it's actually emotional, and sometimes we call that cognitive pain. Especially in children. Okay? So that's why in children sometimes more towards a general blocking the process or perception of pain. It's actually more positive or more advantageous in children, because you are talking about cognitive pain, right? They melekat dalam otak already, so you have to beat that. So it's very subjective. And from 1980s, when doctor realized they are not God, then only they start to study whether they are actually right or not, telling that patient actually just want to complain. Then only the studies start to begin in 1980s. And surprisingly, they found out that it's really significant. Post-operative pain control is adequate, has not advanced significantly for many years. 1980s, macam tu, about 75%. Now, HKL, a few years ago, doing the same study, 79% non-controlled. Okay? Sorry. I think I want to say something, yes, I forgot already. I'm 50 years old. Forgive me for that. Okay. The first, the most recent study says that this actually stays for at least the first 48 hours. So when you're actually doing procedure, make sure you are actually taking care of patients, not just post-operatively. Make sure you extend your concern up to 48 hours. Then some says it's actually 72 hours. By logic, when you are understanding the inflammatory process of the cell, it's supposed to be 72 hours. Okay? But study says 48 hours. Pain is about, most of this is actually about the inflammation. If you understand the inflammatory process, it's supposed to be about 72 hours. Okay? In fact, Kuhn actually do a study in 1990s. They recorded quite high pain score as the 6th day after their operation. This is understandable because when you're actually having the inflammation, you got another cycle of process where at the 3rd to 5th day, then when your macrophage become a dominant cell to actually combat the inflammation, this is where the maximum of the process on the 5th day. So the clearance of debris, so that is actually on the 5th day is actually the maximum. So you can actually understand that. You can have that after about 6 days. And this is what we call sort of secondary inflammations. So that is another level that you need to actually take care of when you're actually talking about the pain. Am I right? NSMO, NS specialist? Yes or no? I think so. Okay. So this is among the reason why we are actually having a very poor post-operative pain, inadequate pain assessment. Kita nak cepat je when you're talking about pain. In fact, that is actually the most important, especially when you are actually doing a private practice. This is your selling point. You take care of their pain well, they will come back, they will start spread the news that, oh, I have been to this clinic, no pain, post-op pun no pain. If you got a pain, you tak payah pergi this clinic lah, very painful procedure. This is your selling point. So that's why you need to assess pain. In fact, when you come up, patient come for follow up, that always remember to ask about the first one with regard to pain. Then only they know that you are like a concerned doctor in terms of the control of the pain. And this is another one. Pain relief is actually a pain. And then I remember when you first start working, yang mana senior bagi, that the one you give, and then you don't even change it. Okay, follow je. The problem is because at that time you do something, you'll be scolded lah, of course. That's why you keep continue or doing the same thing, because your senior also is actually practicing the same thing. Okay, I have actually doing a bit different because I like to read the pamphlet. Okay, dia punya box or that, you got dia punya pamphlet kan. That's among the things that I like to write to read last time. So that's the reason why you are actually brave enough lah. In general, when I'm talking about pain control in Malaysia, you are safe even at your maximum dose. Because Malaysia in terms of safety, is quite good. We are actually at the half. So you got another half to actually go for maximum, at the actual maximum. How many of you all give local to your patient having the overdose? None, isn't it? Because usually the dose that you've been suggested in Malaysia is half the upper threshold. But you have to understand again, when you actually understand the pain cycle, then you know which drug works well, best works well, what's the advantage, disadvantage, what the side effect of that. Then only you actually secure, and then only you actually brave enough to give a different. Then the other thing is methods of the administrations. Okay, takut sangat nak bagi IV, isn't it? How many of you feel that? Most of the time when you actually start working, it's very difficult, scared to give IV, for example. Paling-paling pun you give IM. In fact, certain drug is the best. It's IV because you know that the dose reach the bloodstream and go to the affected site is actually maximum. Like I said, our dose is actually half of the upper dose. So why you actually worried? So you actually wasted a lot of the drug potential when you're actually giving wrong methods. Sometimes we are actually very reluctant to give opioid. Opioid, you know very well, that is actually working not the local. It's actually blocking at certain level of the pain tract. So logically, supposed to be much better because when you actually affect at the local, most of the time you're actually talking about combating the inflammation of that area or signal that actually received by nerve end. Inflammation, when you actually at a certain level, it will never be blocked by any drug. Okay? You tak percaya, you try to give the local into the inflamed tissue, whether it's going to work or not. It never work unless you go into the normal surrounding tissue. You inject into the inflamed tissue, will never work. Okay? So, logically, you have to go yang you boleh handle lah. Inflamed tissue will never work. Then you go somewhere else. Means that you control at the any level of the pain tract. Okay. So how do body respond to pain? This is why important that you actually need to control the pain, especially in the patients that at their level of upper level of the complication threshold already. Huh? Agile patient, old patient, so that you have to actually control, because any stress or extra stress, it will goes into the upper threshold of heart attack, for example. Your respiratory problem, for example, and it will go and then go into that area. So that's why you have to actually be aware of that. Okay. So it will involve the all major and then physiological system. Okay, the how the body respond. You know, you have pain, you having a increased heart rate at least. Sometimes you have a fatigue. So it's all actually involved that. So that's why it's very important for you to control the pain. In the CVS, you will actually increase the sympathetic response when you have pain. So that's why you have a tachycardia, and then you got a when you have tachycardia not responding to your body physiology, then you will have an increased BP, and then you will increase the myocardial work and oxygen consumption of your body. So at the end of the day, you're going to have a myocardial infarction. Because of the poor myocardial function, then you can actually, because of pain itself, can cause death. Alright? In respiratory system, pain from thoracoabdominal wounds may produce pulmonary change, because you're actually holding that, and because movement will cause more pain. So they will actually increase in intra-abdominal muscle tone, and it will also associate with the decrease in diaphragmatic function. So at the end of the day, you will have inability to come or clear your secretion. And you know what's next is actually you can have a lung collapse. Then because of that poor secretion, so that, and then you have, plus you actually just post intubation, for example, you have a very easy pneumonia, and then of course again pneumonia will increase the burden of management of anemia and the pneumonia. Just simple, because you are unable to control the pain, you end up giving more problem that you need to handle. In your GIT, so you will increase the sympathetic tone. You know that actually will actually cause you increase gastrointestinal secretion, one, and then it will decrease the gut motility as well, right? And then so you end up with earliest nausea and vomiting, and you know after that you can actually have the aspirations, whatever reason, and then again after that you can, in fact you will actually decrease your proteins of the body, and then at the end of the day end up with the poor wound healing as well. So pain, and then also will increase the sympathetic tone, and then increase the smooth and muscle of the sphincter tone, and then you have the anuria, okay, urinary retention. And then and the worst is actually that complication will end up another type of pain. So you got gut immotility, then you got bloated. You know very well that nociception for intestinal is the pressure. So and another pain, and then you got another cycle of pain. Your musculoskeletal system, pain will prevent mobilization and increase muscular tone. So DVT, right? And then this is can be fatal as well. So in traditional methods that common, we actually used to use this. In fact, now also still we are using this, in Malaysia at least. So I am petidine. Almost, I don't know how this petidine comes to Malaysia, history-wise, because when I first started working 30 years ago, we have already used petidine. Even now, it's actually we're still using petidine, except in my unit in reconstructive science in USM, we didn't use petidine anymore. Yes, we use Ore and Sec. But you can argue lah, because I'm managing the burn when you're talking about pain, and I am betadine is not so-called good, because you don't want to injure any injury to the skin you don't want. So that's why we always do give an opioid. So how do you decide to do a pain control in your patient? So it's actually depend on patient factor, surgical factor, nursing factor, cause, other factors. Patient factor means that allergy, blah blah blah, and then certain patients require sedations, analgesic with sedations, certain don't need. Okay, so you have to consider that. Anxious patient, for sure you need, if possible, some analgesic that actually having the sedative effect as well. Surgical factor, the severity, certain drug you don't want to actually interfere with your healing process, then you actually need to actually choose that. Nursing factor, how they deliver the drug, so that, okay, if you got PCA, patient control anesthesia, then maybe you actually want to do that. Of course, you cannot run away the cost. Other factor, whether certain interactions of the drug, you need to consider that as well. Treatment of the other treatment that patient have. So at least you have to know the drug interaction and agonistic effect of the certain pain relief. So the commonly used drug is NSAID, opioids, local anesthetic. So, and then the efficacy depends on the type of drug, concentration of the dose, route of administrations, or you add on with any vasoconstrictors agent within the drugs. Vasoconstrictor usually will actually reduce the efficacy of the drug, but increase the dosage that you can actually use. Alright? So, in general, you have to cause pain first before you actually relieve the pain. But don't worry, like I said earlier on, they will never remember this. They remember the actual fact that caused the pain. If that's not controlled, the complaint will come. You actually giving them with big needle, so painful, so they will never remember. They will remember the actual cause of pain. This is when you want to control their pain, they will never remember that. Okay. The problem with drugs of pain relief, they actually got the side effect as well. And the side effect is similar to where you didn't control the pain. It will affect all the system as well. Gastrointestinal instruction, antiplatelet activity, decreased renal blood flow. So end up with the injury as well, and allergic reactions. So that. But the good thing is, it's quite safe because our dosage is actually much lower than the maximum dose in Malaysia. I've used to work in Bangkok. Chlorohydrate, I thought giving 75 milligram per kg is high already. In Bangkok, they give 100 milligram per kg, and nothing happened. So, because the maximum dose is about 200, 150 to 100. Am I right, Anas? But we're giving acid just 50, quarter of it. Alright? So, when we give the effective pain management in the patient will be comfort and satisfaction. You can get earlier mobilization, you will reduce hospital stay, of course you will reduce the cost. Alright? So, what's next? Analgesic corridor. Okay, this is very important. We've never been taught last time during medical school what we are talking about. Any analgesic corridor, isn't it? It's about the constant range of blood level within which they will obtain pain relief. The problem is, because you are talking about modulating the certain system in your body, and you know our system is not identical in comparison to others. it depends on certain other factors. Your activity. When you're talking about your activity, your blood flow throughout the body, your body mass, your blood volume. So that's all actually contributing. That's why you got a quite wide range of corridor. So you have to be aware of it. And this is the reason you need to actually listen to your patient. You dah bagi banyak ni then still complain. Then you start go to mengada-ngada these patients. No, this shouldn't be like that. It's supposed to be, oh, that's maybe because of the analgesic corridor. Alright? So, listen to your patient. So, analgesic corridor is how you are actually giving good amount to reduce the pain but avoiding the side effects. So in between. So give too little, patient have pain. You give too much, you got other side effect. Look at this. From HKL. Between patient there is 5-fold variation in blood level of opioid needed for analgesia. 5 kali ganda beza. That's what you are talking about, the variabilities of the pain control. So, if nothing you can actually accept today is just remember that pain is variable in terms of their presentation, in terms of their response, in terms of the patient, and then whatever it is, listen to your patient. Okay, then only you actually will initiate you to go and read about what drug you're going to use, what's the best administrations, and how the variability of treatment will affect differently on your patients. The key word is you have to go and read. Right? So aim. So the aim is always patients are comfortable. Right? So that's why now almost every hospital got this scale lah. At least they got a so-called documented way of telling their doctors that the pain relief is enough. So semua orang familiar with this chart ni. Okay, ceria or tak sedap tak ni, or cannot see anything. So it's always come up to the effective analgesia. How much is enough? How much is too much? Okay, so you have to go continuous monitoring with your patients. That's why that PCA is very popular. Patients have that control themselves, but again, you are actually being controlled by the setting up of the machines. And if you notice that our PCA also is still actually at the level of usual maximum dose of administrations. Tak ada orang berani nak go double with the PCA. So that's, you cannot do anything lah, because it's actually a policy set up by the Ministry of Health. Alright, so that is general about the pain control. NSMO, okay. For the surgeon, then this is more, or for you all, as a managing doctor to control is actually more procedural, that